Greg Bain on advanced manufacturing surgical training models for shoulder surgery. Platform can be adjusted for comfort of the surgeon into a beach chair or lateral position. This scope is introduced. There's no need to make an incision. You can just advance it through the skin of the model into the joint using standard arthroscopic equipment. We can see the glenohumeral joint, the labrum and the biceps tendon. A diagnostic arthroscopy will be performed. The anterior portal is being created with the aid of a Wissinger rod and a plastic disposable cannula. So just uses standard arthroscopic equipment. The scope's introduced. The trocar can be used as a hook. In this case, the model has a slap tear in it, so the superior labrum is torn, and in a rollback phenomenon, it would move in an abnormal way. There's also a pastor lesion, so a needle can be placed through the subacromial space to identify where the pastor lesion would be. In the same way as we would do in clinical practice, this can be released from the greater tuberosity with the aid of a scalpel. A shaver can be placed into the subacromial space and the greater tuberosity debrided. You can see the arthroscopy is all being performed as a dry procedure. Saline can be added into the joint to help remove some of the debris to make the shaver work more efficiently. In this case, we're putting a double row repair. So this is the medial row. We pre-drill it and pre-tap it. Tends to work better in the models, doing that in the same way as we would if the bone was very hard in a clinical case. Now we're using a tap placed into the drill hole for the medial row. You can see the rotator cuff tear on the left. You can see we don't need to wear gloves because there's no viruses involved. Now the anchor is inserted into position. We identify where the drill hole is. Advance the anchor into position in the same way as we would do in clinical practice when performing a double row repair. Having completed the initial anchor, we then use a suture passer to advance a leading suture through the rotator cuff from inferior to superior. The sutures from the anchor, the first anchor, are advanced through the rotator cuff using this shuttle suture. The lateral row is then secured into a pre-drilled greater tuberosity. We can see the position of that. We then insert the lateral row. So you can see the importance of the technical skills and being able to perform this in the model and how it would be useful from a training point of view. Once the anchor is into position, the introducer is removed and the sutures are cut with a suture cutter. So all of these basic steps can be managed in the arthroscopic models, and we can see we can assess the final position of the rotator cuff repair. They can have this in every hospital or even at home. So the future of surgical training is anywhere